Hello and welcome everyone. We're so happy to be with you today at the Society for Integrative Oncology's special series of Wellness Wednesdays. My name is Marianne Cerrone, and I'm the founder of the Integrative Cancer Review, an online journal devoted to safe, effective, and accessible integrative modalities for those affected by cancer. So today's topic is so important. Is called Words Matter, Mind, Body, Language in the Clinical Setting. And this is so important because good communication between healthcare providers and professionals and the patients and families is so critical in sharing not only information, but also navigating the emotional component of a diagnosis and to convey a sense of hope and compassion. So today we are very pleased to have as our esteemed speaker, Dr. Hilary McLafferty, the author of Mind, Body Medicine in Clinical Practice. Dr. McLafferty is a fellow of the American Academy of Pediatrics. She is board certified in pediatrics, pediatric emergency medicine, and integrative medicine. She is section chief and medical director of pediatric emergency medicine at Tucson Medical Center, and she is on the faculty of the TMC Children Pediatric Residency Program. Dr. McLafferty has also authored Integrative Pediatrics, Art, Science, and Clinical Application, as well as co-authoring the Anti-Inflammatory Family Cookbook, which sounds fabulous. So today's presentation will be about 40 minutes, and then at the end we will have time for questions. So please put your questions into the chat box or watch the raise hand function at the end for live questions. So we are so thrilled to have you with us, Dr. McLafferty, and I will turn the presentation over to you now. Thank you.
Thank you. Thank you so much. And I'll just jump right in. I appreciate it very much. And I have no disclosures, so nothing to disclose. What I am going to cover today are really, I want you to come away with being able to identify 3 elements that are important in establishing verbal rapport, to recognize scenarios in your line of work. So I'll be giving examples from my experience in my line of work, but as I go through, develop scenarios in your situation where strategic word choice can really have an important impact. I want you to be able to list one verbal intervention that you will apply in the next couple of weeks and observe the outcome for yourselves. We're going to cover some background in physiology, talk about the trance state and why that's relevant in the clinical setting. 3 main steps to implement in this approach. We're going to touch on pain, which is a huge topic. So I want to make it clear that we're going to talk about certain elements of this very big topic. We're not going to try to digest the whole thing. And then we're going to conclude with a little bit about taking care of your team, be it a clinical team or a family unit. So there are a lot of ways that this information applies. A couple of cautions when we're talking about the use of language: pre-existing post-traumatic stress. So we want to be as informed as possible about the people that we're working with. If there is mental illness that is diagnosed, that's important to know about and to acknowledge. If there's a history of abuse or any type of trauma, physical, sexual, emotional, neglect, especially in a child, we need to be very cautious and typically partner with a mental health care professional. Or if there's a nonverbal patient, which we encounter in a variety of clinical settings. So we want to be as informed as possible before we proceed. So why is this topic important? And it's really near and dear to my heart. I love this quote by Maya Angelou. So I've learned that people will forget what you said, they will forget what you did, but people will never forget how you made them feel. And I can't think of a more relevant application of this than in the medical setting. So you must increase your awareness. The purpose of this is for all of us. So every word that's said in the presence of a patient, and this again applies in the family unit as much as in the clinical setting, has the potential to either help or harm. You can inadvertently increase perceived pain and fear, which is certainly, no one's intention, or alternatively convey calm and confident encouragement. And we have research that shows that this impacts both treatment outcome as well as patient expectations. So the underpinning research in this area is compelling. And we are going to be talking about trance, and anyone that's familiar with clinical hypnosis is familiar with trance. But if you're not, it's an altered state. Have you ever been reading a book or watching a video, not realizing that someone is calling you to come down for dinner, or, your phone is ringing, or someone's at the door? So you're in a pleasant altered state known as trance. Conversely, trance appears in highly stressful states, and we're going to talk about this element of trance with shock or confusion or fear. At the most sort of difficult end of the spectrum would be a dissociative state. For example, if you've ever worked with a victim of abuse or assault, oftentimes it's very apparent that that person is really not fully present. It's a dissociative state. So how do you recognize trance? It's really a spectrum of behaviors. I was recently in a room with a parent, and I had to give very difficult news to a parent. And as soon as I started speaking, it was apparent to me that this mother was not hearing me. She was not, she was present and not present, not taking in what I was saying. She was in a what we call a trauma trance. So she was just repetitive, sort of saying a couple of words over and over, and just in a state of shock, which is, I understood instantly or within a few seconds that she was not taking in the information. And there are some other physiologic changes that you can see that you might pay attention to in your work or in your day-to-day life, and understand if you can pick out the person that's really with you and present and listening, or if they are in a type of a trance state. You can also get a sense of time distortion, especially with pain. And maybe you've experienced this yourself, where you are having a painful injury, for example, and it feels like, oh my God, it was, 6 hours until we got help or to the ER. And in fact, it was just a short amount of time. So there's this sense of distortion or selective awareness. Someone maybe didn't realize that they were bleeding, or that they had an injury, or, they just can't believe that this happened. So there are a variety of ways that this manifests. Everybody really impacted by trauma, the patient, the family, the onlooker, they are in an altered state. It might be subtle, but I think the job is to try to tap into that and recognize that, because this state stimulates the instantaneous release of neurotransmitters through the thought, the emotional processes, just as other triggers of fight or flight can do. And I'm going to show you a graphic here in just a second. The beauty of this, or the importance of this, is that you can use that moment to tap into the power of the physiologic placebo effect. So let me show you what I'm talking about. Thought, emotion, stress. So at the very top of this diagram, a thought or emotion, a stressor, can create and does create the instantaneous release of stress hormones. It targets not only cognitive function like fear, anger, or joy if it's a pleasant thought or experience, but also the physiologic changes, all of the metabolic axes that you can see here, and it impacts the GI system, the cardiorespiratory system, metabolic, the immune system, and it all happens in an instant. Now, this is important because the autonomic nervous system, or the ANS, impacts and controls all these physiologic factors that we see in the clinical setting: pain, heart rate, respiratory rate, blood pressure, the inflammatory cascade, muscle contraction, and so on and so forth. And this is how we understand this mind-body connection. And these stressful states provide a window of opportunity. You can either worsen inadvertently, like I was saying initially, you can worsen this fight, flight, or freeze state. Oh my God, that looks like a terrible injury. Or you can help trigger the relaxation response. Stay calm, help is on the way, is a simple example, and we'll go through more. So at times of crisis, when this cascade is triggering, there is a window there, and people are especially open to suggestion. And if you capture that skillfully, language can be an incredibly useful tool in the clinical setting, and that helps us make that jump to understanding the real utility of the mind-body therapies, which are gradually moving into the mainstream of medicine. So it's a skill set, and it gets easier with practice. And of course, we're going to find ourselves making a mistake or inadvertently, heading in the wrong direction. You just remember that if you say the wrong thing, or if you trigger a response in a patient or a family member that you want to, oh, I wish I could take that back. You can do that. Just stop and redirect, and we'll go through some examples. It does get easier as you practice it. We do understand that there's a moment there. So PTS, so post-traumatic stress, when you are giving bad news, or you're in a scenario where you do have to, deliver some hard news, there's a moment there where you can inadvertently medically hex somebody. And I'm going to give you an example of what I mean. So, and this is an example that is a real life example. A family had gone through a clinical day with a young child. They had gone through all the testing. They were going to find out how the patient, the young patient, was doing. And they had gone through hour after hour, test after test. It was the end of the day, and they were waiting for the attending to come in and give them the update. Well, the attending had been called away to an emergency, and a fellow came in to give the update and the final summary of the day. The fellow was hovering at the doorway and relayed the fact that in reality, all the testing, all the information was good news. Things had gone well. They were pleased. On the way out of the door, this young trainee turned and looked over their shoulder and said, all we have to do now is wait for the cancer to occur. And the family, that's the only thing that family remembered from that visit. That is medical hexing. The fellow walked out, went on their way, that probably never gave that a second thought. The parent remembered that instant, that feeling of horror, terror, fear, dread for years and years and years afterward. To this day, remembers that. So inadvertent medical hexing is something that we really want to avoid. Our goal, and again, this is aimed at my physician colleagues, but applies to parents as well, caretakers. Our goal is to induce a sense of well-being, even in difficult situations. Now, some of you may be familiar with clinical hypnosis, and I want to talk a little bit about it. I am trained and certified in clinical hypnosis, And it relies heavily on language, and that's how I especially became interested in this topic, because it's so powerful. So clinical hypnosis is not the stage type of hypnosis, right? It's taking that, inducing that really focused daydreamer trance through relaxation, helping the person create an altered state of consciousness. It's completely under their own control. Then you heighten concentration on a particular idea or image, usually to potentiate relaxation, and then help people with therapeutic suggestions, which I'll talk about in just a second. And so it's a very powerful technique, well recognized, well developed, used extensively in clinical medicine. How does it work? So the bottom line is we're not exactly sure, but this article, for those who are interested, is the best summary of research that I have found to date about how it works. Bottom line, it taps into activity and connectivity within and between these areas of the brain, with activation of the lingual gyrus that sort of pulls in that mental imagery. So our language evokes mental imagery that can be extremely powerful. And so if you're interested in this sort of research and what we know so far, I encourage you to look at that article. So how does this apply? There are really three main steps that we're gonna take a look at. First of all, when you're engaging with somebody, you need to establish rapport. Then you need to maintain an effective interaction and offer skillful therapeutic suggestions. And again, this applies as a clinician or in any other setting, in a family unit, in any other team or care setting. So how do you establish rapport? In my work, I currently work in pediatric emergency medicine. We have seconds to establish rapport with the family. We're about to go in and we are about to engage a family. We're about to do a difficult procedure or take care of an injured child, and you need to establish trust and rapport instantly. It's critical. So how do we do that? First of all, and I teach this to my team and I work with my scribe, I work with a scribe. So before we go in the room, we center ourselves, no matter how busy or chaotic, especially if it's busy or chaotic. The more chaos, the more important it is to present in a very centered and calm way. Then you need to establish authority. And we're going to talk about this in more detail in a couple slides. Whether you're a parent, whether you're a medic, whether you're a physician, you want to establish authority in a positive way and then gain alliance. So this is how we do this. So establishing authority. I am in charge. I know what I'm doing. I'm here to help you. What is the purpose of that step? It is to trigger the relaxation response in the affected person, in the patient, in the injured person. Think about a situation. Let's say you're in an accident at the roadside and the ambulance arrives. And what happens? Everybody feels a tremendous sense of relief, right? What if you're a parent and your child is injured? Or if you're going in to take a child to a difficult procedure? I'm here. I know what I'm doing. I'm going to help you move through this. Thank goodness someone's here. In the emergency department, we feel this, for example, if we're flying out a critical patient and the transport team arrives from the tertiary level hospital. The transport team shows up and they bring that sense of authority. We're here to help. We're going to help you get this patient out of here to a higher level of care. Instant reassurance. Now, what's the big pitfall here with authority? If you present as arrogant, if you are not reassuring, if you are cold, if you are dismissive. So this is where you need to have that rapport. And think of how you yourself establish rapport in these settings. You know, how do you show up in a room when you are the authority, when you are there to help? What characteristics do you bring? So you don't want to be arrogant or overconfident. It's really quite a humble way of establishing connection. So then as you're gaining alliance, it's this sort of developing an affinity. You're joining together with the person. We're in this together and I'm going to help you. It's a very instantaneous. Why do we do that? Because we need the person to trust us. We don't want to be in a pulling apart type of relationship. We want to partner with and help this person move through a difficult scenario, a difficult challenge effectively, smoothly, as least traumatically as possible. It's critical. It is critical to be realistic. You don't want to just say, it's going to be fine, don't worry, or just relax. You know, I hear people saying that in the emergency department to a child who's been injured, who's splinted or sick or bleeding. Just relax, just relax. No. You have to be realistic. All right, we got here. That part is over. You did great. Now we're here. The worst is over for now. Our next step is whatever. So you want to be very realistic and you want to solicit help. You want to provide a distraction. I need you to hold this. I need you to hold pressure. I need you to, extend your arm. So you want to be specific, partnering, and establishing trust right away. What's the pitfall here? You must never lie. You must never lie, especially to a child. So you want to be truthful and realistic without giving them a false sense of, I think that's the worst thing is if you lie and then you come, because you lie with good intention and then you come back and say, no, actually, we do need to do this or that. You just want to be incremental in your establishment of trust. And, this establishing alliance does not have to be verbal. And when I go to a room, I will often very quickly figure out who am I going to be able to connect with most quickly. And sometimes it might be the quiet aunt in the corner or the grandmother who's very calm and just sort of exuding this sense of I'm present, I'm here. And it might be just connecting with eye contact. There may be some simple touch, or you might just put a hand on a patient's shoulder, something very quick just to let them know we're partnering, I'm here for you. And then if you can get a verbal contract, for example, this is another way of establishing alliance. I'm going to call for help while you hold pressure, or, we're going to give you something for pain. Does that sound okay right now? Or would you prefer a liquid or a pill form of medication, or talking to the parent in some way that, again, establishes this sense of partnership? Rapport and alliance are facilitated by your sense of confidence, credibility, compassion, and concern. So let's take a look at that. Confidence is not, it starts on the inside. When I teach residents or medical students, it's really coming from the inside out, and it's controlled very much by your tone of voice, by the pacing of your words, as well as by your body language, right? So if a caretaker walks into a room and they're anxious and hunched and, distracted, that interrupts this sense of rapport and alliance. You need somebody who exudes confidence from the inside out. and that is critically controlled by your language. Credibility, basically, the key to credibility is that a breach of credibility is very hard to repair or walk back. Let me give you an example. When I walk into a room, I keep it very brief. I'm Dr. McClafferty. I am the attending physician. We are all here to help you. Picture the opposite of this, a person walking in and saying, I'm Dr. Smith. Well, actually, I'm a medical student. This is my first day on the rotation, and I'm gonna go get my attending and we'll be back. So, you've blown it up. So if you just are confident, brief, and reassuring, that builds rapport and alliance and the relaxation response again in your patient. Compassion and calmness, concern. I recognize this as a higher state of awareness. When I'm working with the patient, it's based on the mirror neurons. So it's basically the serve and return physiology. What you present is returned to you from the patient. So especially with children, what you'll find is what you're giving is often what you'll get in return. And when you're in that sort of synchronicity with the patient, you know it, and you feel that the trust is being established. And it's a really beautiful feeling when you feel that the patient, that you've earned their trust and that you've partnered with them and you're with them in the quest to help them feel better. What happens next then is that you have to maintain this interaction. And we think about pacing. How are we going to move to the next step? How will we lead them? Partnering and establishing a yes set so that they're following you down the path of the treatment and trusting you. And then we apply this with therapeutic suggestions, with clear, specific, firm, and believable suggestions. And let me give you some examples. And again, I work with children, so I use a lot of age appropriate examples, but you can translate that into your own world. And with therapeutic suggestions, there are two kinds, direct and indirect. Direct, you really want to know and be careful to avoid negatives. And I've heard people say this in the emergency department. What happens is what you're saying as a negative, don't die, don't panic, don't move. What the brain hears is panic, move. And so you want to avoid these negative suggestions. You also, so as an example, we would say, can you extend your arm and hold still? Can you take a breath and center yourself? And you want to also avoid some trigger words like your pain. Rather, you would use, how's the pain? Or tell me about the pain. So you don't want to attribute it in a, how is your headache? So you say, describe the pain to me. And that gives the person a little bit more distance from it. Avoid try. Now here's an example. Let's say I walk into a room and I identify myself and I say to you, let's say you're injured and hurt, and I say, we're going to try to reduce your pain. But if it doesn't work, we'll try something else. So that you're like, well, okay. How about if I say, I'm Dr. McClafferty. We're going to address your pain. We have several different options, and you'll let us know which one is most effective. Oh, okay, great. I'm feeling good. I'm feeling a sense of control. This person knows what they're doing, and we've got some options. So it's a completely different setup. And as you're working with direct therapeutic suggestions, you want to start with easy things. Be clear and specific. You can always change course if you need to. And you want to create a sense of positive expectation. We use this all the time, every day at work. And you want to recognize small successes. And probably you have been in this interaction with, you have probably at some point been in a situation, maybe you were getting blood drawn or an x-ray taken, or you were at the doctor yourself. So you respond to simple, clear instructions. Now take a deep breath. Great. Let's do that again and slow your breathing down. That's the way. Excellent. You've got it. That's good work. So, and I will give children feedback like that, just simple, not overly, not over the top, but just simple, reassuring. That's the way. That's right. Now let's do this. Excellent. Next step. And you can lead people. That's how you lead people through a procedure that's challenging and difficult. This example just talks a little bit about the tone of your voice. I was working with a resident a couple weeks ago, and it was very busy, and we needed to do a spinal tap on a young patient. And I said to the resident, and I wasn't looking at them, I said to the resident, who was very competent, I said, here's our plan. You've got this, right? Thinking that they would go in and get started. There was silence. So I had made this assumption, you've got this, right? Nothing. So I look over my shoulder and they're just, like deer in the headlights. And so you instantly recognize that the person is in distress, confused, feeling out of control. And all I did was I say, you've got this. I'll be right in and we're going to work our way through this step by step. You've got this. And they were like, great. We went in and took care of it, right? So simple shift in tone, same words, different intonation, conveying confidence, conveying a sense of control, triggering their relaxation response. Now, indirect therapeutic suggestions are a lot of fun. They take a little more practice, but I love these and I use these all the time in my clinical work. So think of it as because, something, now you can, or as the you can, or as you can. Let me give you some examples. Let's say we're working with someone and they've and a lot of patients, no matter their age, have gone in over and over for repeat visits. A lot of kids, as you know, live with chronic illness. So they're used to things, but it still creates a stressor. So an example might be, because we got the IV in, now you can let your arm relax. Great work. Because the orthopedist is on their way, she can just rest till they get here. There's nothing more to do. As the medicine works, your skin will go to sleep. Then we'll clean it up and put the string bandages in, or whatever we're gonna do. And I use this a lot with fractures or injuries. As the ice pack goes on, as you feel the coolness starting, you can allow the swelling to decrease. You can let the skin feel numb. You can let the skin feel like it's going to sleep around the cut. As you slow down your breathing, you can start to notice how much more comfortable you feel. These simple phrases trigger, remember that graphic of the brain and the metabolic, sort of all the metabolic responses. You can deliberately trigger the relaxation response. A lot of times I will be taking care of a patient, and I'll say to the child as I'm walking out of the room, let me know when you start to feel better. Or I wonder what you're going to be hungry for when that medicine kicks in. Or I wonder what flavor of popsicle is going to sound good. Or when you go home, not if you go home, but when you go home, then you can, whatever it is. And so these are phrases that you can tailor to your situation. They convey confidence. They give patients hope and optimism. especially around pain. And of course, pain is a huge topic. But when you're skillfully addressing pain, you are also capturing anxiety. You're conveying a sense of control to the patient. You're conveying a sense of agency to the children. Mastering these skills, especially in people who are experiencing chronic symptoms, it's a tremendous skill set to convey. So there's a lot more going on than just reducing discomfort. You also want to keep pain in context. You know, what is the history? What do they know about pain? What else is going on? Is this patient exhausted? Are they depressed? You know, what's the pattern? What's the pain pattern recognized by the family? What other stressors are going on? So there's a lot to pain. It's a complicated topic, but you want to be thinking about this in a 360-degree approach. Your bottom line approach, your bottom line sort of goals are conveying calm, confidence, positivity, assurance that they can handle whatever it is, and that they are not alone, that you're partnering with them to get through it. Now, you have to divert maladaptive behaviors. I'm directing this slide to the caregivers, to the parents, to the clinical team, because there are a lot of maladaptive verbal phrases that are used. I hear this all the time in my work, or recently I heard a parent, I heard a parent say to a child, if you don't sit still, the doctor is going to give you 10 shots. And I actually stopped that parent and I said, please don't speak in that way. Please don't make us out to be the bad guy, put terror in this child. But let me give you some examples. So you have to consider your own experience with pain, good and bad, because I'm sure you've had some very bad experiences yourself, and avoid projecting those onto the patient. So for example, avoid prescribing what's going to happen. Get ready, this is going to hurt. What about, and I use this all the time, I'll say to a child that I'm about to a suture, or maybe we have to inject a little extra anesthetic. I'll say, listen, the cream that we put on made this area of skin go to sleep. It's asleep. Now we're going to put a little extra numbing medicine in there to be sure that everything is fully asleep. You might feel a little bit of pushing. You might feel some buzzing or tingling. We don't really know. So I'm curious, I wonder what you're going to feel. And so when we do the next step, you leave the door open for the child or patient to have their own experience. Tingling, buzzing, pushing, pressure. There are a lot of other words than saying, get ready, this is going to hurt. And I hear nurses say that, for example, in our ED all the time, and it really might not hurt. You just don't know. It really might not. So other strategies can be dissociation. When we work on your leg, and I used this the other day for a child where we were doing a thing on their arm, I said, now the pain medicine's in, while we're doing this to your arm, the rest of your body can just relax and watch the cartoon. Mm-hmm. And they were like, oh, okay. And they were watching the cartoon. Or we saw a pretty bad thermal burn about 3 weeks ago. There was a bad electrical burn, and the child was in a lot of pain just coming in. And we were, getting the team ready. We were putting in an IV and all that, but we weren't there yet. People were getting things ready. And I said to the child, listen, right now, just imagine that there's a snowstorm and the snow is just falling on that arm, feeling cooler and cooler and cooler while the team gets everything ready. Let your arm feel like it's covered by snow. And so this triggers the physiologic changes that help reduce the inflammatory response and mitigate pain. You know, so kids especially are great at this. You can also transfer the location of pain. Let the pain of the whatever you're experiencing flow down to the tip of your finger, and then you can just let it float away. Or you know, maybe they've described the pain of a headache to me. Describe the pain. What does it look like? What is it? What color is it? What shape is it? What size is it? All right, now let's let it fade. Let's let it shrink. Let's allow that to get smaller and smaller. And people feel a sense of control. For a lot of times with GI pain, with gut pain, you can use this idea of, can you find the switch? Let's turn that pain down a little. Find the knob. Can you turn it up? Oh, okay, good. Now let's see if, now let's turn it down. And you give this, again, you give them different opportunities and ways to address the pain. And you want to engage all the senses, especially with kids. You know, you want to be brave, you want to be strong, or maybe there's some funny sensation, like a tickling sensation. So depending on who you're interacting with, you want to evoke not just a visual, but also a sound, a scent. You know, you can involve all the senses. So there are a lot of ways to approach, and you can capture the senses with your language. Ideally, and this is an important point because a lot of patients do live with chronic illness, ideally they come in with a skill set that you can enhance. And so if you work with patients, or if you are in a family where there is a chronic illness, you can begin to lay groundwork, foundation, so that when you arrive in an acute care setting, you're not coming in empty-handed. The patient has some tools. And in the ER, we often don't have that luxury, right? We're working with the patient that we've just met, and we're trying to convey instantly the things that I've been talking about. So it's always better if you've got some baseline knowledge. I also really emphasize with my team that from the first contact, from the first time the patient walks into our department, our triage, our registration, what they are receiving from the team is calm, confidence, competence, compassion, from the very first to the last thing they experience as they walk out the door. So it's very much a team approach. Our goal, of course, is we want to reduce anxiety, convey optimism and realistic hope. We want to enhance a feeling of control and self-efficacy, and then build mastery over and over. So in summary, what you say matters. And I encourage you, I invite you to expand your vocabulary and do it very consciously. Think about it. Listen to yourself and listen to your team, or listen to your family. How do you talk about illness? How do you talk about pain? How do you talk about stress? Think about laying groundwork to move in a really positive direction. And then think about how you establish rapport. How do you show up in a room, both as a patient, so the clinician is coming in, and they're getting cues from you, and you're getting cues from them, and you can help set groundwork for an open, trusting discussion, and you can lead a clinician in the way you want to go. And I do this all the time when I go into a clinical setting as a patient. You know, I use these skills to help the clinician help me more effectively. I do that all the time. Develop skillful therapeutic suggestions. What are the things that you might use over and over? So for me, I help people with breathing. I help people hold still while we're doing tough things, tough procedures. I help people manage pain while we're repairing broken bones or whatever. So, you know, I have certain patterns of things that I do over and over again. And I like to play around with the language and keep growing my skill set. And so develop your library of therapeutic suggestions, and then really, really recognize the power of your words. Especially over the past year, I just want to touch briefly on this idea of taking care of your team. This could be taking care of your family, right? Getting people through tough stuff. We've been doing this all year. Acknowledging, listen, the worst is over. We did our job. We did all we could. Great job, everybody. Our goal is that we wish for the highest good, the best outcome. We did everything we could. And that's how we debrief after very tough scenarios, which we've seen over and over and over again this year. You have to take care of your team. And as a clinician, you are a leader and people are looking to you. As a parent, you are a leader. People are looking to you to be effective in difficult scenarios, and you can grow your skill set. These are some of the references that I use, and I offer these to you. Certainly there are many more. And with that, I'm going to conclude and thank you and leave time for questions. So I'm going to unshare my screen. And there we go.
Thank you so much, Dr. McClafferty. That's really a wonderful presentation and such helpful information. Really, what a set of life skills that everyone can use to be more mindful in using language. One of the questions I have is, how can patients use this information if they are working with practitioners who may or may not be sharing in the same skill set? And in the meantime, I invite everyone who has a question to write it in the chat, and we will get to it as well.
Yeah, I think that in the clinical setting as a patient, I think that people really underestimate their ability to control the pace of the interaction and to have that sense of confidence in asking a question. So I would encourage patients to think about their desired outcome before they go. Hopefully they're not in an emergency setting where things are happening fast, but even if it is an unexpected visit, I would really encourage everybody to understand that they do have a lot more control than they think, and to slow the pace by asking the questions, by slowing their own pace of speaking. So rather than say, oh, doctor, I just have one more question. I don't want to hold you up. Say, thank you. I understand. I heard what you said, doctor, and I have a couple of questions. I want to understand more fully the point that you made here. What are our other options? What are the side effects of this approach? Are there other things that I should be aware of? And just have that sense of, the doctor may feel pressure and feel rushed, but while they're there with you, you want to encourage that engagement. You can take the initiative and establish rapport. I've had patients say to me this year, I see that the unit is very busy, and we really appreciate your being here and working through this pandemic. Thank you for being here for us. So how does that impact me as a physician? I'm so grateful. I'm leaning in. I see that they see what's happening to me. So you want to just extend that sense of humanity. We're human beings, and we appreciate that sense. But and slow the pace of your tone of voice and ask respectful questions that engage rapport. And I do want to say that if you're in a doctor-patient relationship and you never feel able to do that, you always feel like that person has a foot out the door, or they're not sitting and engaging with you, even on the busiest night in the emergency department. I sit, I pay attention, I am in rapport with the patient, and no matter what's going on, if you are not able to establish that with your clinician, then find a different clinician or have a talk with them, with that clinician, and say, listen, I'm just not sensing that you're present here with me in the room. And if you get a response that's not kind, professional, compassionate, look elsewhere. It's critical. It's critical.
Yeah. Yeah, that's a really beautiful way to put it, to engage in that kind of dialogue. So we have a question. It says, in cancer care, we often hear language such as battling cancer, the war on cancer, the patient lost the fight, the patient failed treatment. Can you comment on this type of language and the use of it?
Yeah, I think the critical point there is everybody that is dealing with any chronic illness, especially cancer as an example, you are really looking for this sense of alliance, of positive progress, no matter the prognosis. And so, you need to have this sense of cultivating the tools that will help the patient move through the experience in the best way possible. And I think especially the term, lost the battle, I think that just really misses all the rich potential and engagement. That's the skill set that you're trying to help the person acquire. I have seen patients heal and move positively through a terminal diagnosis. So you want to really understand, what is the patient's goal? What are the patient's needs? Where are the patient's strengths? How can we harness those most effectively? So I really think that black and white language is not, it's simply not helpful. And I think that that's part of the importance of this work in addressing clinicians and helping them understand. So I work and teach physicians, and a lot of them don't have this awareness, don't have this skill set. So I think there's a real gap there. And I think that as a patient, hopefully you would be able to bring that up with your clinician and say, we'd like to use this language, this approach. This would be more helpful to our family. And one would hope that clinicians would be receptive to that.
Thank you. Where do you see the evolution of this skill set in terms of the healthcare environment? Do you see physicians, nurses, other healthcare practitioners being more aware and having these skills, or do you feel like it's mostly in the newer trainee students that are coming up?
Yeah, I think that's interesting, because we are paying a lot of attention to trainees. We're working with medical students. We're embedding this information. I've worked with developing curriculum and embedding information in the integrative practices into conventional healthcare models, typically with students and residents. But there is a tremendous interest in the more sort of mid-career and older physicians, especially in areas where people are treating chronic illness, such as in oncology. So I think there's a lot of interest and a lot of work to be done. So and that's why we do this work, and I partner with my colleagues, because there is a big gap that we're trying to address, for sure.
And how did you get inspired to focus on this area?
Okay, so when I was training and in my first work in pediatric emergency medicine, there was development of the field of child life. And so they would come in, and it was very new, and engage with the child, distract the child, and then we were able to do our suturing. We were able to do our work, and I was just blown away, because previously I just kept going away from interactions thinking, I mean, we were doing tough stuff to kids, thinking, is this really as good as it gets? Is this really the best we can do? And I'll also offer to the group, you remember the example of the parent sitting in the clinic with the young child and receiving that information from the fellow, who then turned and walked away. Now all we have to do is wait for the cancer to help. That parent was me, and that was my family member. And to this day, I can evoke that feeling instantly of dread and fear. And that's many years ago. So it's really a personal and professional work for me, for sure.
Yeah. Amazing the way you've put that experience into the world in a positive way, helping so many people too.
Yeah. I think it's really important, powerful tool.
Yeah. We have another question on, what are your thoughts on the use of language when working with unresponsive or coma patients?
So very interesting, because we know that obviously very individualized. So I'm going to make a general statement here, acknowledging that every case is different. But we know that the auditory sense is one of the last to go. And I think, there's some really compelling research in the area of, for example, music therapy, sound therapy. That's where the study of sound on the brain with fMRI studies show us that received sound is incredibly powerful in patients who are comatose or post-op or heavily sedated. And so then the use of voice, and we also have research showing that the maternal voice, for example, in an infant or in a baby, evokes relaxation response. So we have some sort of pockets of research there. So in people who are working with patients who are comatose or in whatever stage, I would really encourage you to harness that positive, reassurance, confident. You don't have to go overboard, but just that sort of calm, confident reassurance, absolutely. And we certainly use that in the acute care setting also. If, like, I recently was working with a patient who was, very altered, a very young child who had altered mental status. And one of the tools we were using, along with all the other things we were doing, was reassuring, centering, calming, letting this child know that they were safe, being taken care of. So yes, I'm in hearty endorsement of the use of voice in those scenarios.
That's fascinating and so important. Yeah. Okay, I think we're at the end of our time now, so we'll wrap up unless there's any other question that you haven't been asked that you would like to address.
Well, no, I would just say to people, don't be afraid to, a lot of times in my clinical work, I use this all the time. Like, I practice this way of interacting with patients, of talking with patients, and I'm very deliberate, and I know that people are paying attention to what I'm saying and how I'm interacting and how the patient is responding. So don't be afraid to be a little bit of a leader and push yourself slightly out of your comfort zone, and just start playing around with language, even in your personal life, and start noticing the difference that you can make. So play with this and be confident in its use.
Yeah, that's so helpful. Thank you so much, Dr. McClafferty. We really, really appreciate being here.
Absolutely.
So,
My pleasure.
yeah.
Thank you.
Yes. And I'd like to thank all the attendees for being here and the SIO staff and our excellent support group that we have helping us. Our next webinar will be next week on July 28th, which is Navigating Cultural Differences in Decision-Making, Understanding Hispanic Family Systems and Cultural Constructs, presented by Dr. Manuel Moya Tapia. So we look forward to seeing you then, and thank you again so much.